Okay, good afternoon and welcome to our webinar Wednesday on liver cancer. October is really well known as being Breast Cancer Awareness Month, but it is also Liver Cancer Awareness Month. And we are so happy today to have a clinical speaker to talk about this today. Just as a reminder, please remain muted when you're not speaking. Our webinar is being streamed to Facebook Live and will be later uploaded to YouTube. For those of you who are joining us on Zoom, please use the chat box to ask questions throughout the presentation. And to those of you who are joining us on Facebook Live, please use the comments section to ask any questions that you have. The Webinar Wednesday series is part of a broader initiative called Healthy You, which is a community and University of Chicago cancer education initiative. And it's brought to you by the University of Chicago Comprehensive Cancer Center, Office of Community Engagement and Cancer Health Equity. My name is Aaliyah Poulos, and I am an education outreach specialist in this office. For those of you who have any technical issues or anything come up during Zoom, I'm the person that you can send a message to, and I can try to help with that. Our speaker today is Dr. Anjana Pillai, and I'm going to stop sharing my screen and allow Dr. Pillai to go ahead and introduce herself and share her screen.
Thank you, Aaliyah, and thanks everyone for joining the webinar today. Sorry I'm not dressed up for you all. I'm on inpatient hospital service, so I'm in my scrubs. But I wanted to just talk about Liver Cancer 101, given that this is also, as Aaliyah pointed out, Liver Cancer Awareness Month. So this is a subject that's very dear and near to my heart. This is what I specialize in and what we spend a lot of time making sure patients get transplant for if that's the right indication for them. And I think it's just really important to know about your liver and your liver health. So I have tried to make this more patient-friendly and non-provider oriented, I should say. So if there's anything that's not clear, please feel free to write in the chat or even speak up. I don't mind at all. So I always like to start off with this slide, and essentially what this shows is that the amount or the incidence of liver cancer, so HCC stands for hepatocellular carcinoma, which is primary liver cancer. It just really varies around the world. So the darker areas, the very red areas that you see in parts of Africa and Asia, especially China, are areas with the highest incidence of liver cancer. And whereas, in North America, in the United States, we have a lower incidence of liver cancer when we're thinking about the world in general. A lot of the reasons why people have liver cancer vary across the world, and the vast majority of it happens with patients with chronic liver disease, and specifically with cirrhosis or advanced liver disease. So this is, again, another depiction of what I just showed you, and this is data from the World Health Organizations for 2020, looking at different types of cancers. And so liver cancer, as you can see, is the third most common leading cause of cancer-related death worldwide, right after lung cancer and colorectal cancer. So it is an important cancer that we need to be aware of. Now, what I was saying earlier is that it's very important to know who is at risk for developing liver cancer or HCC. I'm going to use those two terms interdependently. This is a liver that's not normal. So this is a picture of a normal liver, and this is a picture of a liver that has scarring or cirrhosis. So the vast majority of HCC or liver cancer occurs in the background of cirrhosis, so up to 90%. There are the most common causes of cirrhosis. It can be fatty liver, it can be alcoholic liver disease, it can be hepatitis B, hepatitis C, or a whole host of genetic and other factors. Now, what happens usually is you have an insult to the liver, whether it's any one of these, alcohol, fatty liver, viral hepatitis. And over time, if it's not treated appropriately or if the insult is not stopped, it leads to a chronic hepatitis or inflammation of the liver, and that eventually leads to scarring of the liver. And once you have cirrhosis, which is extensive scarring of the liver, then you are at increased risk of developing liver cancer. So again, most patients with that develops HCC or liver cancer occurs in the background of someone who has chronic liver disease, specifically cirrhosis. Now, this is data from a study a few years done, about 2017, and this is looking at the top 15 causes of cancer death in the United States. And what you can see is so the minus numbers shows that most of these cancers are decreasing, but you can see on the plus side, liver cancer is number 7, and it is also one of the fastest rising cancers. So we are seeing more and more liver cancer in the United States as well. So, there's a couple of important things. One is that, like I said, this primary liver cancer is about 85 to 90% of cancer that occurs from the liver. The other is bile duct cancer, which we're not going to talk about. And unfortunately, most people are diagnosed when they have symptoms or when they have more advanced disease. So the 5-year survival rate is pretty low. And like I said, it is the 3rd leading cause of cancer-related mortality right after breast and colon. And usually because patients are diagnosed late with symptoms, survival is not as long. So we are doing a lot of things to try to help prevent that. And so there is actually data on who should undergo testing to look for liver cancer, just like we have data to see who should get colon cancer screening or breast cancer screening. So we have data for that. And then also treating people with known risk factors like hepatitis B, hepatitis C, also vaccinating for things we can like hepatitis B. All of that would help decrease the risk of advanced liver disease and also of liver cancer. Now, as I was saying earlier, etiology of liver cancer around the world versus the United States is quite different. So if you look at this pie graph, which is it's supposed to equal 100%, you can see a little over a third of it is due to non-alcoholic fatty liver disease or fatty liver, which largely does happen in the context of patients with diabetes or glucose intolerant or pre-diabetic, as well as patients who tend to have obesity, and especially to carry obesity around the central area, so around your abdomen, okay? Now, the other group is a group with hepatitis C. This used to be the #1 cause, but we had a significant shift in this when new therapies for hepatitis C came out several years ago, and now people are cured more often. So now the amount of people that have hepatitis C has decreased. Hepatitis B in the United States is a less likely cause, and then alcohol is the third, almost equivalent to hepatitis C or a little bit more than hepatitis C is alcoholic liver disease. And this has actually gotten worse, especially during the pandemic. Now, globally, the most common reason is hepatitis B, especially in areas of Asia, including China and sub-Saharan Africa, and then alcohol, and then hepatitis C versus other. So there is some geographical differences. Now, the other very important thing that this is showing is, again, the darker red the colors are, that means higher incidence, is that fatty liver around the world has increased. More people have risk factors for non-alcoholic fatty liver disease, or NAFLD as it's called. And there are certain areas of the world that's very, very prevalent, including India over here. What happens with fatty liver, as I showed you earlier, it's also one of the risk factors that can increase, it's also one of the etiologies of liver disease that can increase the risk of liver cancer. So this is just showing that fatty liver related liver cancer is increasing worldwide. So all of these countries over time have had quite a large increase. So China has had the largest increase with up to 82%. And in Europe, France has the largest increase, and the US, the increase is by 122%. So we do need to work on the obesity issue, diabetes, better control of all those metabolic risk factors. And this is a graph that's showing that historically 5-year survival, which we talked about earlier on, is not that great. And so this is, this is data from 1973 to 2007. So it's a little bit older data, but this was published in New England Journal of Medicine, which is one of the premier journals. And what it shows is that over time, although over time, really the survival hasn't really increased. And that again is because we're getting people later than we should. Now, there is surveillance recommended by societies. These are all the different societies that recommend surveillance. And what that means is they've identified a group of people that are at risk for liver cancer, and that they're giving guidance to what we should do. So the surveillance, once you have identified a group of people, is ultrasound every 6 months at minimum, and plus a tumor marker, but although our guidelines doesn't say that everyone has to have that specific tumor marker, and that's called an AFP. So, and the idea of surveillance is really to catch people at an earlier stage when you can treat them effectively and ideally cure them. So all these different societies throughout the world have some sort of guidelines that to help catch HCC or liver cancer at an earlier stage. So this is our main liver society. It's called AASLD. And so what we recommend is that for Asian men with hepatitis B over the age of 40, Asian women with hepatitis B over the age of 50, anyone with hepatitis B that has a family history of liver cancer, African or North American, African Americans with hepatitis B, or anyone with hepatitis B that has cirrhosis, all could benefit from the surveillance, which again is an ultrasound every 6 months. The second group is really anyone with cirrhosis. So anyone with cirrhosis should really get an ultrasound at minimum every 6 months. And again, the idea is to detect liver cancer earlier. Now, the group that we're not quite sure about if we should undergo surveillance is people that have hepatitis B but don't fit these categories up here, or people with hepatitis C or fatty liver that do have scarring, but they don't have cirrhosis or advanced scarring. So that data still needs to be worked out. Now, what do we do if someone has liver cancer? So let's say that you have an ultrasound, and if you have a lesion that's less than 1 centimeter, which is quite small, you can keep following with ultrasounds to see if there's any change. If it grows, then you would get a CT scan or an MRI of the abdomen. Now, if you are doing surveillance, and again, there are people that meet those guidelines that I showed you, and you have a lesion or a mass or a tumor in your liver that's more than 1 centimeter on ultrasound, then you really want to get a CT scan or MRI. And there's a specific way that liver cancer looks like on these imaging studies that you don't necessarily need a biopsy to prove that you have liver cancer. So when you get a lesion that's more than 1 centimeter and you get the specific either a CT scan or MRI, and you have to write it, we as providers write it in a way that lets the radiologist know that we need contrast and we need it timed in a certain way because we're looking for liver cancer specifically. Now, if that comes as yes, it is liver, yes, it meets that criteria, then it is liver cancer. If one study says, you know what, it doesn't look like liver cancer, but we're not sure, then you can try, CT is not completely confirming it, then you can do an MRI, and then usually that will confirm it. If both studies really don't show classic liver cancer, what we usually recommend is to repeat the scan in 3 months over a certain period of time, or consider a biopsy. So that's kind of how you approach someone that's undergoing surveillance that has a lesion in their liver that's concerning for liver cancer. Now, this is a normal liver. It looks like a triangle right here. This is in your abdomen. It's a CT scan. And if you look at this scan right here, you see this bright white spot. Now there's lots of spots, but I'm talking about this one right in the liver. And then you see like on a different, so it's all the same scan, but it's looking at different faces. You see it's right here, and then you see that same spot is dark. So that's very classic for liver cancer. And if you don't do anything and you're not quite sure, you see that that grows. So again, this is kind of the imaging that we use to see a liver cancer. That's what I wanted to show you. Okay. And so if and if you're not sure, then we repeat it in about 3 months, and you see that the cancer can grow. Now, besides imaging studies like an ultrasound or a CT or MRI, the other question is, can you use tumor markers? So the most common tumor marker that we use is called the AFP. So it's so not every liver cancer tumor secretes that marker, but about 67% does. About 60% does. So it's a good one, but it's not perfect. So if your cancer is one of the 30% or so that does not secrete AFP, it does not mean that it's not a liver cancer. It's just that if it secretes AFP and it's very high, then it's an additional information that tells you, okay, this is likely liver cancer. The one that we use at University of Chicago, this is the sensitivity, meaning how likely is this going to be liver cancer, is this score, which is a combination with AFP and 2 other scores, and that's pretty high. That's about 85%. So it's not 100%, but it's pretty good. Now, once you have liver cancer, let's say you know that you have cirrhosis, you've been undergoing your surveillance, you're following with your doctor, they found something, they confirmed that it's liver cancer. What are your options? So if your liver is healthy enough, and if the lesion or the tumor or the cancer, these are all interchangeable words that we sometimes use, can be removed by surgery, we prefer resection. If not, if the liver is not healthy enough, because I told you the vast majority of liver cancer happens in patients with cirrhosis. And so oftentimes the liver is not healthy enough to get surgery or to remove a part of the liver, then you need a transplant. So those are your surgical options. And so when we look at, actually, let me go back. So there's surgical options. There's other options too. There's what we call local regional therapy options. This is not, I know there's a lot of information here, but this is just to tell you there's many different ways we can treat liver cancer, which is a good thing. We have so many different ways to approach it. And so that's when you treat the cancer locally, meaning you can burn it, you can put chemo beads in it, you can put radiation beads in it. Or if it's a little bit more advanced, you can do chemotherapy in itself. And there's all these different chemotherapy options now, which, we didn't have that many options even about 3-4 years ago. So when we look at the best outcomes is really for transplant, because we say that, even if you resect or remove part of the liver that has cancer, and you still have that underlying cirrhosis, there's always a risk of new cancer. Whereas with transplant, you can take out the old liver and you get a new liver. So you're not only removing the cancer, you're also removing the liver that's sick. Okay. So ideally, this would be the option that has the longest survival outcome. So when do we decide resection versus transplant? It really depends. Resection is a great option, especially to delay transplant in someone, because you need long-term immunosuppression, you're needing medications. So your liver, which is foreign to you, will not reject, your body won't reject it. So the good thing is, if you are able to get resection, there's no waiting time, because you don't have to wait on a list to get a liver transplant, and you have really good survival, but it may come back. Right? So there's a recurrence risk. Recurrence means that the cancer may come back because you still have a liver that's scarred. And because most of this happens in the background of advanced liver disease, the number of people that can safely undergo a resection is not as huge. Now, a transplant is great, like I told you, because you can take out the diseased liver and treat the cancer, and it's a very good 5-year survival. In transplant, we look at things with 1-year survival, 3-year survival, 5-year survival. That doesn't mean someone only lives a year or 3 or 5, but when you have a 5-year survival of over 70%, it's a really good sign. Ideally, we want everyone to live as long as their natural lives after transplant. Now, the problem or the con with transplant is there's not readily available organs. There is a big national waiting list that you have to go on, and liver cancer does get priority, but you still have to wait. And so if you have to wait, there's always a risk the cancer can grow or spread. And so as I said, the benefits is there's a chance to cure the cancer and there's a chance to cure the underlying liver disease. But practically there is a shortage of organs and longer wait list time. So this is the criteria we use. I just wanted to throw this out there. If you ever, if anybody's on that has a history of liver cancer or going through this, the criteria that we use that the governing body in the United States that helps with organ placement is called the Milan Criteria. So that means you can have one liver cancer, but it has to be no bigger than 5 centimeters, or you can have up to 3, but none of those 3 can be more than 3 centimeters. So if you have more than that, you have to treat them so that it comes down to this criteria. And then of course you cannot have cancer into the main big vessels of your liver, and you can't have cancer outside of the liver, because if that happens, getting a transplant is not necessarily going to help you. The whole idea of a transplant is you want to catch it when it really helps, the cancer has not spread outside of the liver, and that you can have a really good long life. And so so United Network for Organ Sharing, that's the governing body that kind of looks at this, and this is the criteria that's been accepted because people have really good long-term outcomes. Now, there's all these different local regional therapies that I told you about briefly, and all this means is that if you have one lesion, you can actually, rather than getting chemotherapy throughout your body or through an IV or through a pill, you can go straight to that lesion in the liver through either the side, through your skin, or through the groin area, and actually either ablate it or cook it, or put chemotherapy beads or radiation beads in it, okay? And then the other option is the systemic therapy. So before, there was only one medication called sorafenib. That was from 2008 to almost 2018. There was nothing else. But now we have a plethora of medications. So again, treatment for liver cancer has really improved over time, especially in the last several years. And there's a lot of options for patients now. And this is just telling you kind of like, I just thought it was an interesting slide that tells you over time how many treatments have been approved. And you can see most of them started in 2017, 28. So there's a big time where we didn't have a lot of options, and now we do. And these are two, so this medication that was approved in 2020, it's a combination of 2 medications. It was the first one that had better survival than the original medication sorafenib, which was approved back in 2007, 2008. So last year was a really big year for that reason. And there's a whole bunch of trials also underway looking at other combination of medications. So the other thing that I want to really leave you with, besides kind of looking at what liver cancer is and who should get surveillance for liver cancer and what the treatment is the importance of a team of doctors, a team approach to caring for these patients. Because unlike a lot of cancers that happen in healthy organs, like breast cancer happens in a healthy breast for the most part, pancreatic cancer can happen in a healthy pancreas, whatever have you. Liver cancer, vast majority of times happens in a sick liver. So you have to be an expert at liver disease and cancer. And so that's why we rely on this big multidisciplinary team of people that really understand all aspects of liver cancer and also able to do different things. So I'm a transplant hepatologist, so I do the medical part of liver disease. I also do endoscopic procedures. The surgeons are the ones that would remove part of the liver if you got a resection or a surgery. The interventional radiologists are the ones that would help do those local regional therapies along with the radiation oncologist. We have surgical oncology and oncology that helps us with the systemic therapy. So really it's a team effort. And this is our program. So I'm the medical director of our program. And as you can see, we have transplant hepatology, so transplant medicine, transplant surgery. We have more hepatologists and surgeons than this. This is just kind of our core group. We have radiation oncologists. This is our medical oncologist. We have a lead tumor coordinator, advanced nurse practitioner. We have diagnostic radiology experts who read these films in our tumor board, which happens every Thursday. So we have clinic every Monday. We have a tumor board every Thursday. And then we have interventional radiologists that help with many of these treatments. So our approach is a complete team approach. And that's really how patients get a good outcome rather than going to different doctors and trying to navigate things on their own. So in conclusion, there is a rise globally and also within the United States of liver cancer, regardless of why you have liver disease. There's several guidelines that tell you how or what you should do if you do have a risk factor for liver cancer, but we need to make sure patients are educated about it. We need to make sure that your physicians are following it. There's a lot of treatment options, and that's why these multidisciplinary teams are so important, because you don't want to just go see one person, they say, okay, you should do surgery, or see another person, they say you should do chemo. You want everyone to look at all the options and look at you as a person individually and say, this is the best thing for you. There is a very unique benefit of liver transplantation for liver cancer, which is different from a lot of other cancer therapies, right? The benefit of removing a diseased organ and putting in a new organ that can be curative. But again, as I told you, there is a waiting list, and sometimes, that can be a problem. And the type of therapy that we offer by our interventional radiologists, whether it's microwave or like kind of cooking or heating the tumor, or radiation beads, or chemotherapy beads, that really depends where the tumor is, the number of tumors, the size, the location, also at your institution, what your institution is good at, because really the outcome that you want is the best outcome for you. So if your institution is really good at this specific modality and everyone that gets this does really well, then that's the one that you should use. And then systemic therapy, meaning chemotherapy options, as I showed you, up to 2017-18 really had one drug, and now we have a multitude of drugs and ongoing trials. So that's great. That helps people live longer. And then lastly, again, just emphasizing that these multidisciplinary teams are very important in optimizing personalized care for each individual patient and best treatment outcomes. And that is my talk. Thank you for listening. I will stop screen share right now. So happy to answer any questions.
Thank you so much, Dr. Pillai, for all that really great information. I'm going to relay some messages that came through in the chat box. Reminder for those of you who are watching on Facebook Live, please use the comments section to ask any questions, and I will be monitoring that. So the first question we have here is, do we know why the incidence of liver cancer is increasing? Is it increasing, or are we better able to detect it?
Yeah, that's an excellent question, actually. So it is increasing, and we're able to better detect it. So the primary reason in the United States is really a combination of things, but fatty liver disease. So again, people that have what we call metabolic risk factors, meaning that people that tend to be more obese, especially around their midsection, have diabetes, cholesterol issues, heart issues. So so that kind of whole group of symptoms fall under that umbrella of metabolic diseases or metabolic syndrome, and that increases your risk of fatty liver. And fatty liver is one of the main reasons now that we are actually doing liver transplants as well as liver cancer. And the other one is a rise in alcohol use as well. The pandemic definitely hasn't helped that, but long term. So but also we have established surveillance, like you pointed out. We know who these patients are that should undergo surveillance, and our scans are much better than they were 5-10 years ago. So it's a combination of both the incidence is increasing, but we're also able to detect it. But the most important thing is that we need to make sure that people that need surveillance are actually undergoing surveillance. So you have to be an advocate for yourself too. I think that's why these things are so important. So you know, okay, you know what, did I get my ultrasound this, it's 6 months. So I always encourage my patients to work with me so that we're working together for you.
Great. There's a question here. Are partial liver transplants from a living donor common in the treatment of liver cancer?
Yeah, also a really great question. Yes, so we do living donors, and yes, so in the United States, as opposed to other countries, certain Asian countries, uh, you know, uh, or other areas of the world where living donor, meaning, one person gives part of their liver to someone else while they're still alive, is more common. In the United States, deceased donors are more common. So patients that have passed away and have indicated that they would like to be organ donors. But yes, a living donor is just as good as a deceased donor for treatment of liver cancer. And the advantage of that is that you can schedule a surgery and you don't have to necessarily wait, on that wait list until your turn on the list comes up per se. So what we do say, we will still want to treat that cancer. We still want to make sure that cancer is under control. But if you have a living donor, then we can schedule that surgery.
And can you explain a little bit more about someone who's a living donor, what the risks would be? To me, I think some people will hear, donate part of my liver. That sounds crazy, but can you explain a
Yeah,
little bit about the
yeah,
risks and the benefits of that?
yeah. So living donation has been done for a long time. Actually, the first adult living donor to a baby was done at the University of Chicago.
Wow.
And that child is now an adult and alive, got part of her liver from her mom. So, you are donating a part of your liver, yes, and the amount varies whether if you're, donating to a small baby versus an adult. But the idea is the remaining liver that you have will grow to its full size within 3 to 6, or at least 90% of its size within 3 to 6 weeks. So that's a remarkable ability of your liver to regenerate. So that's really important. Now, when we think of a living donor, we take lots of precautions. We make sure that the donor is very healthy, that they're doing it because, out of their own volition, that they're not being coerced. So there's a lot of team members are involved in that. But overall, it is a very safe surgery. It's been done well and throughout the world. And your own liver does grow back. So you should not have any long-term deficits or issues. Again, we are very careful to who we select because we want to make sure that both the donor and the recipient have the best outcome, because we're now putting, two people at risk, right? So we want to make sure that everyone has a great outcome. But yeah, it is, you'd be surprised how many people come forth. I'm always humbled to see that for, their not just their family members, but friends and even strangers that they don't know, when they read a compelling story about someone who's really been struggling with liver disease and just cannot get a new liver.
Wow. So there's a question here. Will they allow you to be resected while you wait for a transplant?
So it depends. If resection is the best option, then you do that first. So, and the idea is if that resection shows that you're cancer free, then you don't necessarily need a transplant. Now, if that resection goes bad for some reason that we misjudged and we thought the liver would do great, but it didn't, then yes, you would then then you would be worked up for a liver transplant. But the idea is that if you're resecting someone, hopefully that the resection is going to last, the results of the resection is going to last for quite some time, and you don't yet need a transplant. In patients with chronic liver disease, whenever we're talking about resection, we really make sure that, as to our best of our ability, that we know that that liver is going to be able to handle it. Now, if after the resection, let's say the patient does great, but 6 months later, a year later, there's a cancer that returns, then we have to really talk about transplant.
Are there any physical symptoms for liver cancer?
So this is a really important question about liver cancer and liver disease in general. You know, liver disease is kind of a silent disease, is what we describe it. Like unlike your stomach or pancreas that can hurt when it's in pain, your liver really doesn't give you a lot of symptoms until it's sicker. So what we want to do is, that's what I was saying, we want to identify patients that are at risk before they have symptoms. That's why when I showed you those survival data is not that great, because when patients present with symptoms are more advanced. So if you have yellowing of your eyes, yellowing of your skin, fluid in your belly, loss of muscle, loss of weight, lack of appetite, those are all concerning symptoms for cancer. And usually when you have those symptoms, not always, your cancer is more advanced.
So there's a question here about
I just want to make sure that I'm clear. So the idea really is that we want to catch people before they have any of those symptoms. Because I will hear my patients sometimes say, I feel so good. Do I need this? And I'm always like, yes, this is perfect. I mean, it's not perfect, but you feel well, you're strong, and you're able to undergo a transplant. And this is where that was the whole point of doing surveillance before you got so sick.
There's a question here about the hepatitis B vaccine for adults, particularly in immigrant populations. So what is your view on getting the hepatitis?
Yeah,
I'd love to hear a little bit more about that too, like at what age people should get it and all that kind of thing.
So anyone that comes to my clinic, I look to see if they're vaccinated for hepatitis A and B, just because they're so preventable and we have these amazing vaccines. So any adult that comes into my clinic, that's one of the first things I check for when I do my workup. And so, yes, I mean, children, you start these vaccine series at birth, actually. Not at birth, but as a young, as an infant. So if you didn't get it as an infant, then, usually when you start school, they ask for vaccine recommendations. And then, as you pointed out, for the immigrant population, it's a little harder to make sure that they get vaccinated. Now, is it covered under ACA? I don't know that, because there's so many different types of the Affordable Care Plan. I don't know if that's something, Aaliyah, you can look into,
Yeah, don't know off the top of my head, but it's something we can look at. Don't know how insurance works with the ACA all the time.
Yeah, it really depends on the insurance that you have.
So do you recommend, if an adult has come here and they, or even if they're born here and they just didn't get the hepatitis vaccine, can they get it as an adult?
Yes, absolutely. Yeah. So if you come from an endemic area, so I don't know if you remember one of the first slides I showed you are like areas that have that red areas that have a higher risk of hepatitis B. So people that come from endemic areas absolutely should get tested. But I always test everyone, because people that come to see me obviously have some form of liver disease. So I want to know what I can help treat. So I check for hepatitis B. I check for vaccination for hepatitis B and A, because even if you've never been exposed or you don't have it, I do want you vaccinated. That's two things that we don't have to worry about that you will ever get. And it's very effective vaccine.
Someone said, are spots on the liver found incidentally, like a CT scan or something else? Are those of concern? So are spots on the liver that are found incidentally of concern?
So, as I told you, I direct our liver tumor clinic, and as much as we see patients with liver cancer and bile duct cancer, a good number of patients are seen for lesions that are incidentally found, as you're saying. So meaning they went to go get a CT scan for a completely different reason, and they found something in the liver. So it really depends on what it is. There are benign lesions that we just happen to see that will never cause any problems, like cysts are one of them, and then you don't need to do anything. And then occasionally we do see real cancer that needs to be treated. Usually they're benign, but it really depends what they are. And so a lot of times when someone has one of these lesions, their physician or sometimes the patients refer themselves to our clinic, and we look at the imaging. We go through with our tumor board. Like I told you, there's a big, about 25 of us that meet every Thursday to go over these images, and we will let patients know, yes, this is something that's concerning, or no, really don't ever worry about it. But remember, you have this so that the next time someone scans you, it doesn't, turn into like a big thing.
And thank you
And
to
I think
Ivy.
Ivy just shared that A and B are covered. So
That's great. Thanks for sharing that, Ivy. I have a question here, and I'm not sure if you answered this in your presentation. Is there a genetic component to liver cancer?
yeah, so it depends. So the short answer is no, but we do see clusters in families. So for instance, like if you have hepatitis B, you have a family history of liver cancer. It's a hepatitis B that puts you at risk for liver cancer. But then we, like those guidelines that I showed you, then we screen you earlier. Or if you have fatty liver disease, and I showed you that's a growing reason for liver cancer. And if you have other members of your, a common thing I see is especially Latina, Hispanic women that say, you know what, my grandmother, my mother, and my aunt had cirrhosis, they never drank. And we find out most of that's to fatty liver or had cancer. So then I know, okay, there's an increased risk of fatty liver and cancer in that family. So I know that you might be more higher risk. And so then I screen them a little differently. But it's really because of the underlying liver disease that's leading to it rather than a true genetic predisposition, if that makes sense.
Yes, that does make sense. So not quite like BRCA1 or something like that for
Correct.
breast cancer.
Yeah,
Okay.
exactly. But there are people with fatty liver disease that have a specific gene that increases their risk of liver cancer,
Okay. And then do you have any just general sort of advice about how to care for your liver in general, to
You
to
know,
reduce your risk of those diseases?
obviously I'm very biased, but I think it's a very important organ. It's an organ that does so many things that most people just don't think about their liver, because it just kind of sits there and does all these different jobs. But if your liver ever fails, you're in a lot of trouble. So, I tell people general things like, kind of like I guess what your mom would tell you, like eat healthy, don't, minimize processed foods as much as you can, try to get more fruits, vegetables, lean protein, like kind of that Mediterranean diet. We know coffee, there's something about the cocoa beans and coffee that's healthy for your liver. We know cooking with olive oil is healthy for your liver. Really, really limit your alcohol intake. There's so much data that's coming out that, alcohol intake varies between individuals. And oftentimes I've also had patients, husband and wives retired, they both drink the same amount, every night. And then the wife comes in with liver, significant liver disease and advanced liver disease. So men and women metabolize alcohol differently. So, and also you don't know if you have something else that's predisposing you to liver disease. So let's say you have hepatitis C, you didn't know about it, and then you drink every day on top of that, then that can increase your risk of advanced liver disease. Same with fatty liver. If you're a risk factor fatty liver, you drink every day, can increase your risk of advanced liver disease. So, eating well, minimizing alcohol use, exercise. There's a lot of data that shows exercise is healthy. Obviously we know that, but it also releases a lot of good good endorphins and decreases the bad or anti-inflammatory we call them cytokines, but like these humors into the body. So exercise helps with decreasing that. And then the other thing that's very important is to avoid like herbals and supplements, eating a healthy diet, a multivitamin at most, as you get older, especially for women, calcium, vitamin D, checking a vitamin D with your primary care, see if you need that supplement, but you don't need tons of herbals and supplements. And many of these herbals and supplements that are sold even at GNC and nutrition stores, they're not necessarily FDA approved. They can increase your risk of liver disease and liver, and we've actually had cases of liver failure from it. So, and then also to make sure, you're vaccinated for preventable things like hepatitis A and B, so you don't get those diseases.
That is a great list of things that we can do. So thank you so much for providing that. The supplements, Wouldn't have
Yeah,
thought of that. That's
yeah,
a
it's a
really
big
good
thing,
point.
supplements are, it's a big market, so you have to be very careful because, everyone knows someone that tried this and like this performed a miracle. But, on the other side where I am, we've definitely had to do transplants for patients because they've taken something that's supposed to promote liver health or some other health and ended up in liver failure.
Oh, wow. Good. That's a good warning. Okay, any other questions for Dr. Pillai? I'm going to check real quick and make sure that none have come through on Facebook. For our Zoom participants, you can either unmute yourself and just ask directly or
Yeah,
keep using
please
the
feel
chat
free to
feature.
just,
Okay, I don't see any coming through on Facebook Live. And I don't see any more here in our chat box. Okay, then Dr. Pillai, again, huge thank you for talking about this with us today. Liver
yeah,
cancer, like I said, one of those cancers that just doesn't necessarily get the airtime that a lot of these other ones do, like breast
yeah,
cancer. So,
yeah.
so we're really grateful for you to be able to spotlight this today, especially during Liver Cancer Awareness Month. And we will definitely be sure to share this information and share this webinar far and wide so we can get the word out about caring for our livers and preventing liver cancer.
Well, thank you. I appreciate it, and I appreciate all of you staying on all this time. And thank you.
All right, thank you, Dr. Pillai. Have a great rest of your day.
You too. Thank you.